bone will reach in the middle, and the gap that will remain in between these two frontal bones in the newborn will give the suture. And you see here how nice we can see the fontanelle already in the newborn, and the fontanelle are done for the delivery in order to facilitate the head extraction. But the sutures are not only places without bone. There is a strong interaction between the bones. There is a complex embryology with different changes at the different times of the development. And we know that there is an interaction not only between the two bones, but also between the bone and the dura mater, with signals that change during time, and the embryology of this region is yet not completely understood. We have the help of animal models in which we can modify one or two key genes and change completely the fate of this region, but still the complete functioning is yet not completely understood. So at the end, we will have this baby with this suture. You see the two coronal suture, the anterior fontanelle, the sagittal suture. You see the beginning of the lambdoids. There is still a metopic suture, but we will close physiologically around 7 to 9 months of age. And you see on the right image again, the view from above, the anterior fontanelle. These sutures are essential, as I said, to the delivery and then to the growth of the skull in the first month, allowing to adapt to this important growth of the brain from the different ossification centers. And then afterwards, the role of the suture decreases, and the mechanism of growth will come, like in our bones, by positional resorption. The brain pushes from inside, the bone is resorbed, and the new bone is formed outside and on the outer layer. And so you have a volumetric increase little by little, and there will be this increase in size, maintaining mostly the same proportion to adapt to the growth of the encephalon. And for this, there is an active role of periosteum helping in the ossification, and also a role of dura mater, as we said, and the physical pressure from the brain to do the resorption. So we have an outer layer that is osteogenic, and an inner layer there is more osteodiasis. This is for the skull vault. The skull base, as we said, is different embryologically, is different in a type of ossification. It's endochondral. There is a cartilaginous shape, and then it ossifies little by little. They are interrelated, but they go distinctly. We can have a skull base growing even if the brain is absent, and with this skull base will not have suture but have synchondrosis, which are again cartilaginous bridges that will allow the growth. And then you see much later during time, around for some at the adolescence, they will fuse when the growth is not needed. You see here an example of dissociation. We have a normal skull base and a very large growth of the vault. So the space does not grow because it's dysplasia, but the skull vault is very large. And here is the contrary. There is no brain, there is no skull vault, but the skull base is still present in that encephalon. The growth of the skull base also continues later on, but this is also the case for the face, for the mandible. Different part of the skull grow at different rates at different times. In the first years, it's essential to have a large development of the vault in order to adapt to the skull growth, and the face will start to develop much later. The nose, the mandible, as you know, will become at adolescence very later during the life of the child. This growth needs the very tight equilibrium between the different factors that prone to ossification and prone to reabsorption, modification. There is an equilibrium which is very fragile and involves several genes, several molecular cascades that we know more and more, involving several genes that you may recognize if you do also neuro-oncology, because these are the same genes that we found in embryology that we found in oncology, for the simple reason that these genes participate to the growth, and you can easily understand that when they are overactivated, they can lead to neoplastic lesions. So these are the same cascade that we start to discover in malformation, in embryopathy, thanks to the studies. Drugs, they need several different players and different families of genes play together in order to have this ossification. And these genes are better and better known. But there are not only genetic problems, you can have also external factors. And nowadays, I see a very recent paper, we know that there are also unexpected factors may intervene in the skull growth very indirectly. You see here that changing the microbiota in the mice, we can modify the length, the size of the skull. So you see that there are lots of factors that we yet don't know that might play a role in the growth in general and in growth of the skull in particular. So there are several factors for the skull growth. As we said, the metabolism, the bone characteristic, the presence of the suture, the quality of the dura mater and periosteum, and you see sometimes, like in this case, some pathologies can alter this equilibrium. We have on the left a cephalohematoma, which is a calcification of the periosteum. This place, it will help calcify the structure, and you will have a thicker bone that little by little will be resolved by the growing beneath. On the right, you see the modification of the skull vault related by the pressure which is increasing. In case of raised intracranial pressure, you have the so-called thumbprinting that shows that there is a high resorption due to high pressure on the bone, which is faster than the apposition of the outer layer. We can have also tumors, and this will be discussed later on by my colleagues. You can have problems in this migration or in the closure of the different layers. This is an example of scalp pleata cutis, in which there is a defect of the scalp over the vault. There can be also a bone defect due to this problem of migration of the cells, and you see that it can specifically involve some areas and not all of them because of the different embryonic origins. And this is an example in which we can have meningeal defects, skin defects, bone defects. In the severe case of aplasia, the brain is completely exposed at birth. In other cases, and this also will be dealt later, the problem of the closure defect with mass and the lie of the meningoencephalocele, and sometimes you can have problems like in this case of one suture, which is the growth of the shape of skull, the simple synostosis. You can have complex synostosis, in which you can have problems with the skull vault, but also skull base, the face, problem with the CSF, and several other elements that will be presented later. We can also have the problem of the content, because again, as we said, the skull needs to adapt to the brain. So if the skull is normal with normal suture, but there are some content pathology, cerebrum, CSF, you can have a change in the shape and size of the skull. We know that the intracranial volume is determined by the sum of brain volume, CSF volume, blood volume, which is a constant, but this can be modified in the case of pathologies. We can have increasing content with some kind of tumor with hydrocephalus, and this will modify the size of the skull. We will have a macrocrania. Now, conversely, we can have an atrophy that will lead to a reduced brain, a reduced brain volume, and thus we will have a microcephaly. And of course, these elements are essential to be determined by the measurements of the head circumference. And you can see in the very severe cases, the atrophy will lead to a reduction of growth and a modification of the skull shape. What also plays a role is the psychomotor development and the muscles. This is very true in primates, for the muscles are attached to the skull bone. This is less true, but also true in humans, in which the elements of the occipital nuchal line or the temporalis muscle can modify the shape of the skull. And of course, this is very true for the orbits. If you have an ocular problem, the orbit will not grow and the shape will be modified by the absence of growth of the organ. And this is also true for all the face and in general for all organs of the human body. And then there are external constraints that can modify the shape of the skull, and these are important to know because they are easy to solve, and it's important to recognize as a differential diagnosis of all the problems we discuss. This is typically a problem of the skull deformation related to the supine position with the posterior plagiocephaly brachycephaly. The child stays too much on the line position, and this will result in a flatness, but also modification of the position of the ears and the face. And you see that when you put the nose at the vertex, the front is displaced, the ears are turned, and the posterior part is flattened. Yeah, this is how it will appear in the on the child, and this is important to recognize there in the first 6 months of age, because we can try avoiding this supine position to improve the shape of the child and avoid to have sequelae, because we know that if there is a position of plagiocephaly brachycephaly, you can have all facial anomalies that can stay. This is a child who was not, in which the problem was not recognized. You see there is a mild deformation of the forehead, of the front of the head is still tilted even if the child is age 7, and when you put it straight, you can easily recognize the deviation of the face and the mouth. So all these problems are all purely related to the bad positioning of the child in the first month of life, and they need to be recognized and treated. So several factors, external constraints we mentioned, but also other external factors like trauma can modify the skull shape. This is typically what you can see, the very young one with the so-called ping pong fracture, the press fracture. You can have groin fracture in children, which also modify the growth. In these cases, the dura mater is altered, the arachnoid is not, and you have a secondary herniation of the brain content due to the importance we mentioned earlier. So remember, when you're observing and examining the child skull, you need to think about how is the metabolism. You can have indirect also information by the teeth, the tooth appearance, if there are signs of rickets. The suture are present, the dura mater and brain needs to be normal, as this psychomotor development should be, and of course no external constraints and other factors, as we say, in order to obtain a normal skull. So you need to see the overall shape, but also the symmetry of the parietal bossing, the symmetry of the eyes and orbits, the symmetry of the forehead, the symmetry of the posterior part of the skull are essential for your clinical exam, as is the head circumference, in which you need to have not only one point, but all the curve, because once the child is in one category, it should not change, and any change in one side as another must lead to the medical attention in order to be sure that there is no problem with the content or with the skull. So I thank you for your attention, and now we continue with the program of the. Thank you. And of course, you're all invited to Toronto. As we said, the question will be at the end.
At the end, Federico, at the end, yeah?
Continue. So, thank you, Ron.
So good day, everyone. I'm Ronnie Baticolan. I'm a pediatric neurosurgeon at the Philippine General Hospital in Manila, Philippines. I'm also the Communications Vice Chair of the International Society for Pediatric Neurosurgery and Education Co-Chair of the Asian Australasian Society for Pediatric Neurosurgery. Today, I'd like to give you an overview on the diagnosis and treatment of encephaloceles, so both anterior and posterior encephaloceles. So let me begin with this. So if you're going to pick up something from this talk, it's just these 3 key points. So number 1, watertight dural closure is essential for these procedures. If there's hydrocephalus, you must address it. Number 3, you need to plan your skin closure before you make your first incision. So your encephaloceles, these are essentially malformations characterized by bone and dural defects with herniation of meninges, brain, and cerebrospinal fluid, or any combination of these. So just remember, they represent about 10 to 15% of all neural tube defects. So the overall incidence is about 0.8 to 3 per 10,000 live births. And then most of them, of course, are congenital malformations, although you could have secondary encephaloceles. We classify them based on the anatomic location of the skull defect. So you see here, this is just an illustration. This is in the WHO guidebook, I think, where you see where they divide them, your anterior and your posterior encephaloceles. So interestingly, the anterior encephaloceles are more commonly seen in Southeast Asia and Central Africa, whereas the posterior encephaloceles are more common in North America and Western Europe. So for the anterior encephaloceles, the most common, so we usually label them based on where you see the defects. So that and that's what you need to remember. This is the classic paper by Suanuela identifying the classification or enumerating the classification of your sincipital encephaloceles. So let me just point that out. So for example, here, this is the normal anatomy. It's very important for you to try to look for the nasion. So this is so on the sagittal cut, so this is normal. So this is the frontal bone, and this will be your nasal bone, and you see the nasion there. If you see here, if you look at letter B, so the midline defect is here. So you will see that the defect, so the brain tissue CSF herniates to the defect, and the defect is above the nasion. So we would call this a nasofrontal encephalocele. So this would be a nasofrontal encephalocele. In contrast, if you look here, so the defect is below the nasion. So you see the nasion is here, and the defect now is through the ethmoid. So this is what we would call a nasoethmoidal encephalocele. So again, so these patients, they can look very similar, but if you review the scans, you just try to look where's the herniation. So, and again, just look for your nasion. Now, if sometimes they would occasionally herniate not directly in front, but laterally, so into the orbits, so that Suanuela would label that as a naso-orbital. So it could be a nasoethmoidal orbital encephalocele, just because the middle wall of the orbit is involved. So again, look here. So in a nasofrontal encephalocele, it's above the nasion, but if it's below, it's a nasoethmoidal. This is clinically important because in some instances, your nasofrontal encephalocele, you may be able to repair them without the need for an intracranial repair. Some would do just an extracranial repair for this, but that would be impossible for a nasoethmoidal encephalocele because it's a very long tunnel. It's very hard to attain the watertight dual closure. So again here, so this is what you would call a nasofrontal. This would be nasoethmoidal. And this one, they would call this a basal encephalocele. So 10 to 15% of all neural tube defects, as expected, if you don't have folate fortification, then you would have a higher incidence of these conditions. Just embryology, it's because of sustained connections in the neuroectoderm and the surface ectoderm. That's why these lesions will be covered by skin or an epithelial layer. It can have associated abnormalities. But the most important thing is this. So how do you assess if you are presented with a patient like these? what are the most important questions that you should answer? So for me, so this is just based on my experience. First, ask yourself, where's the lesion? Is it anterior or posterior? Is the lesion ruptured? This is clinically relevant because, of course, if it's a ruptured lesion, then it requires urgent repair, especially if there's CSF leak, and you would want to prevent meningitis, brain abscess, ventriculitis. Is the lesion grossly infected? I would not want to repair a lesion that's grossly infected without giving some antibiotics first. So, for example, if it's grossly purulent, you want to gain some control over the infection first. Otherwise, it will be very hard. It will be very hard for you to get good wound healing, and the patient might just get a CSF leak later. Does the patient have concomitant hydrocephalus? When it comes to concomitant hydrocephalus, you need to be able to differentiate. What we've noticed is that your posterior encephalocele, they are the ones who are more likely to require CSF diversion. With regard to the anterior encephalocele, just pay close attention because these are usually, they tend to be associated with arachnoid cysts, and you need to be able to make sure that the arachnoid cyst doesn't have any communication with the meningocele sac. And then finally, what are the associated problems? Is the vision compromised? So for example, some of these lesions can be so big that they're compromising vision. So for example, and that would make your repair more immersion. So for example, here in the second photo, you could see how the vision on the right eye would be compromised. So we would tend to try to do the surgery earlier for these patients. For the posterior encephalocele, important note for brainstem dysfunction, because that will also let you know whether it might be possible or not to do the repair for these patients. We would normally just do a cranial and facial CT, and if possibly the 3D reconstruction. For the posterior encephalocele, an MR venography will be very helpful because you want to see where the torcula is. Goals of treatment: number one, you need to be able to close a skin defect. Number two, you need to be able to close the bone defect. As much as possible, I tried to close the bony defect. And then number three, you need to try to preserve as much as possible the viable neural tissue. So let's go through these individual cases. So your frontoethmoidal encephalocele. So here you have a 4-month-old boy with a nasal mass. So again, you can see it's normal skin covering, delivered preterm at 31 weeks, and the nasal mass has been noted since birth. Was discharged after 2 months. In the interim, the nasal mass gradually enlarged. Head circumference was within normal limits. So if you try to assess this patient, you would see, is this, you now question yourself, is this hypertelorism or is this just telecanthus? Is this skin lesion? Is the skin thick enough? Because, it's always balancing. When would you want to do the surgery for these patients? Do you want to do them right after birth, or are you able to wait a bit more so that they're able to grow a bit, gain a bit some weight, and able to tolerate the surgery? So when you look at the 3D reconstruction, so you can see the defect is here. So the defect is here, and try to look for your nascion. So the nascion is here. And so we would label this as a nasoethmoidal meningoencephalocele. It also involves a orbit. So some would actually call it nasoethmoidal orbital meningoencephalocele. And you can see that. So how do we repair these patients? How do we repair the encephalocele? So remember, the goal is you need to be able to seal off. So there's this dural defect. You need to be able to seal off that dural defect and put some bone over there as well. I would recommend putting bone over the dural repair because this is abnormal dural. It will not regenerate. It will not regenerate bone. This is our experience in the Philippine General Hospital. My colleagues published this a few years ago, and really most of them would really have an unremarkable postoperative course, and you really get complications because of CSF leak and surgical site infection. Most of them would have a good outcome, and this is how we would normally do them. So we would normally do these with our plastic surgery colleagues. We do a combined intracranial and extracranial repair now. And as I've said, particularly for your nasoethmoidal meningoencephalocele, it would be hard. Personally, I wouldn't recommend just doing an extracranial repair alone, because what you want to do is to try to be able to find normal dural. So these patients would get a bicoronal incision, and then we would do so here, this is rostral and this will be caudal. So they would get a bicoronal incision. We would do a mini craniotomy, mini frontal craniotomy, and then elevate the bone, and then try to find the dural defects, seal off that dural defect, usually with the pericranial graft, and then put in a vascularized pericranial graft onlay, and then replace the bone back. We don't usually put metal implants. We usually just use PDS2O sutures. And you see, because he's an infant, this bit will just regrow bone. And then our plastic surgery colleagues would take care of the extracranial repair. I'll do the individual steps later. I'll have a bit more photos. So you can see here, so essentially we follow the same technique. And regardless of how, so the size of the defect, so I said it determines what kind of incision you would try to do. You try to, of course, to make it nice so that, as they get older, it actually becomes less noticeable. Now, our practice has been not to trim off all gliotic tissue. So usually we try immediately post-op, we try to leave a bit of, so you can see here, for example, you can still see some bump. It's because we don't try to shave off everything. Because over time, what we've seen is that this will flatten. And if you try to shave off everything, they get a depression. And that's also not so nice. There are techniques to correct hypertelorism. So you can see here the box osteotomies, and you can read up on this. Now here, so you can see this is another case. So again, very similar looking. But when you examine the scan, if you look at the defect, where's the defect? The defect is right here. And your defect is above. So if you see here, the defect will be above the nasion. So you would label this as a nasofrontal encephalocele. So again, what are the goals here? Same thing. So we do a bicoronal incision, and then we close up the dural tear, the dural defects. And then what we usually do, if we can split the frontal bone that we elevated, that's what we use to cover the bony defect. And then our plastic surgeon colleagues trim off all the excess skin. This one is quite impressive. This is an interfrontal encephalocele. It looks, they can get this big, and you see vision is compromised here. So as soon as we got this patient, this is an infant, we've set him up for surgery. You can see here, it's an interfrontal encephalocele. It's in between the frontal bones. And in these cases, because, the bony edges can be readily identified, you don't need to do a frontal craniotomy. So these patients would, if these patients would just get an extracranial repair. So we didn't have to do a bicoronal incision for this patient. And again, the crucial thing here is you need to be able to find the normal dura. Now, for the posterior encephalocele, so this is a boy with a posterior scalp mass, initially shunted at a different hospital, and then came to us because of the midline, the mass in the back. Now, the crucial thing here is identifying where is the sac, where is the encephalocele sac. So if you look at this diagram, the CT 3D reconstruction, this is your lambdoid. This is your lambdoid suture. So this is what we would call an interparietal encephalocele. So for your posterior encephaloceles, we label them as interparietal. Okay, so interparietal if it's above the lambdoid sutures. If it's below the lambdoid sutures, then those would be your occipital encephaloceles. And your occipital encephaloceles, you describe them, you label them depending on the relationship with the torcula. So they can either be supratorcular or infratorcular encephalocele. But some would argue actually that most of them are infratorcular encephaloceles. So for this boy, so you can see there's a defect here. What would be your goal here? The goal is not just to remove this mass, but to try to repair the dural defects, try to repair the dural defect and the bony defect. Now, what are the crucial points you need to remember? Now, many are actually quite afraid of working in the midline, especially working around the sinuses. But there are techniques to help you avoid catastrophic bleeding. And for me, what has worked for me is that you have to remember, if you're going to encounter bleeding here, you will encounter it at the midline. So whenever I'm doing these cases, so you can see, remember, when you do your dissection, this is how we would operate. So the patient is put in a prone position. So the way I would do it, I would start dissecting from the sides first. So I would start dissecting from the sides first, and you can see usually the sac separates well with the subcutaneous tissue. And you dissect from the side, from either side, left and right, and you work your way to the midline. By doing that, you ensure that you don't violate the midline early on where your venous sinuses are. And you can see here, so you dissect all the way, okay? And it's much easier to dissect the sac when you don't rupture the sac. And here is another crucial thing. So you see here, what I've done is we've encircled it. And then what we do, so you see this is the periosteum. So try to palpate the bony edges. And then 2 to 3 millimeters from the bony edge, you do your monopolar cautery. And then you push it inside. And that will expose the bony edges. It's very important to expose the bony edge because what we try to do is, because this is cortical bone. And what you need to do is you need to drill off that cortical bone to expose the spongy bone. That's because that will be important for our bone graft later. So now after that, so you see here, that's what I've done. I pushed the dura to expose the cortical bone. And then here, you will see when now open the sac. So when opening the sac, how do you prevent venous injury? How do you prevent injury to the veins? Again, just work from the sides. So start working from the side, dissect, and don't try not to violate the arachnoid. Almost all tissue that's herniated is already non-viable, so we try not to preserve them. So we just trim that off. And then the other important thing, when you're trimming this off, what I try to do is I trim off about 4 or 5 millimeters from the edge, so that if tissue retracts, then I will still be able. So for example, if a vessel somehow retracts, and I will still be able to see it. So I don't resect it flush to the bone. I leave a bit of cuff so that it will be easier to coagulate if there's some form of bleeding. So there's usually generous soft tissue to be able to do watertight dural closure. And you see what I've done here. So what I will do here, I will close this off, and then I would drill off the cortical bone. So you see here, I've drilled off the cortical bone and harvested the adjacent parietal bone. Now, this child is less than 1 year old, so we expect this donor site to eventually ossify. But this really needs bone because this is abnormal dura. This will not regenerate bone. Right? And this is how we close it. And just to show you, this is how it looked like after a few months. So unfortunately, the child's got the shunt pulse function, so it had the CT. But you can see here how very nicely the donor site is now ossifying. And then you can see how well the bone graft has taken. And you can see here in the sagittal reconstruction how there's no bony defect anymore. Some of my colleagues actually would not replace bone, but I've seen patients who've only had the dural defect and the skin defect repaired, and they come back still with the lumps in their back, especially if there's concomitant hydrocephalus. Now, the timing of repair, as I've said, you need to consider a few things. First, is there a risk of rupture or CSF leak? If there's a risk of rupture or CSF leak, you need to do surgery urgently. Otherwise, if it's normal skin covering, vision is not compromised, I try to wait maybe between 3 to 6 months so that they'll be able to tolerate anesthesia, blood loss, and approximately 3 to 4 hours of surgery. And as I said, if there's active infection, so we do get these patients who come from other institutions with infected encephaloceles. We try to load antibiotics first, make sure they're not septic, and then we bring them to surgery. So complication avoidance, so make sure there's no infection. Pay particular attention to CSF dural closure to avoid CSF leak and vascular injury. So the prognosis is dependent on the amount of neural tissue within the encephalocele sac. And again, in general, the anterior encephaloceles, they tend to have better neurocognitive outcomes. The posterior encephaloceles, they tend to have some developmental delay. And you have to be able to explain that to the parents. It also depends on the neurologic malformations and infectious complications. Of course, if there's ventriculitis already or meningitis, then the outlook would be much poorer. So again, key points, if there's hydrocephalus, you need to address the hydrocephalus first. So in some patients, if there's a very large occipital encephalocele and there's pressure, I would shunt first before repairing the encephalocele. Otherwise, you run the risk of CSF leak. Right? And then plan your skin closure before you cut. Again, last in illustrative cases, so you see here, again, you have a 1-year-old girl with a posterior neck mass. So you see this mass, skin covered, initially born with the mass and then sent home. And then they came back to us, delayed developmental milestones, but see the head is almost as big as the encephalocele sac. This is what the MRI showed. This is a Chiari 3 malformation. So you can see it's a posterior encephalocele. This is this would be an infratorcular encephalocele. So this is your torcula, and you can see their cerebellum, it's a bit of the brainstem herniating. So how do you do surgery for these patients? Key points. Number 1, again, don't resect flush to the bone. You could see that's already some of the dorsal brainstem herniating there. You need to balance how much tissue you're removing or how much you're putting back. When you're putting back tissue into the posterior fossa, remember that they will have a very small posterior fossa. So you also need to trim a bit of tissue because You don't want to be stuffing all this abnormal tissue into the posterior fossa, and they will get tonsillar herniation. You also don't want that. Again, how to avoid these vessels? Try to work from the sides. Okay, so the safest way to do it is to do your dissection from the side. So you position the patient this way. Again, this is how it looks. So this is superior, this is inferior. And you can see this is working around it. Okay, this is where we transect the stalk. As I've said, I don't resect it flush with the bone. I work from the sides. Once I've identified the sides, I trim it. And then I close over the dual defects. And then close the skin. However, this patient 2 days later, the child developed stridor and the mother reports feeding difficulty. What's happening here? This is the initial CT. There was progression of the hydrocephalus. So take note, when you repair occipital encephalocele, especially very large occipital encephalocele, there really is a risk of hydrocephalus. So you need to keep an eye on them. Okay? And sometimes the symptoms can be very subtle, just abnormal cry, just stridor, and difficulty feeding. So I put in a shunt and the child did well. But as I've said, this child had developmental delay, so the posterior encephaloceles tend to do that. This is another child with recurrent meningitis after head injury. When we did the CT, here's what we saw. You can see there's a basal frontal defect. So this is a secondary encephalocele. So the child kept getting treated for meningitis at the local hospital and even treated as a TB meningitis. But when we reviewed the scan, this is what we saw. But the principle is the same. So you do a bicoronal incision, do a small frontal craniotomy to be able to access the frontal base. We put in a bone graft, and this is the images after 3 months. And the meningitis episodes resolved. 5-year-old boy with a nasal mass, so you can see. So what we've noticed is that also in these patients, they tend to have telecanthus, meaning to say it's really just a soft tissue, but the interpupillary distance is actually normal. If you look at the CT, again, look at your nasion. The nasion is here, so the herniation is here. So we would label this as a nasoethmoidal encephalocele. And here, that's just showing you the bony defect. The nasion is above. And this is a 3D reconstruction looking from above. This is your cristagalli right there. There's an arachnoid cyst. There's this arachnoid cyst or parencephalic cyst, but this was not communicating with the sac, so we didn't have to do anything about this. This is what you need to bridge. So remember, when you do your craniotomy, the tricky part is getting here, because you need to be able to put a dural graft to bridge this gap. Okay, so you do a frontal craniotomy and bridge this gap. So this is how we would do it. Bicoronal incision, this is top, this is bottom. We do a small frontal craniotomy. Once you've removed the bone, you will now be able to access the sac, dissect it. Okay, cut the dura here, amputate. And you will see you will be able to go to the base. And then here we were able to suture this close primarily. And then we like to put in a vascularized graft. So usually either pericranium, we put in the pericranium here, some soft tissue, and then put in the bone. So here we have some excess bone, and that's what we use to cover the bony defect. Again, we just use 2 OPDS sutures. So that's it. Thank you.
Ronnie, that was an excellent talk. That was really good. Tremendous experience. Yeah, tremendous experience you have.
So thank you very much. Now, thank you, Luca. Luca Massimi from Rome will present the craniosynostosis.
Thank you, Fede. Thank you, Jeffrey and Arthur, for involving me in this seminar. I have the hard job to summarize in 15 minutes the management of single suture synostosis. That's why I will give you some flashes, mainly based on my experience. I try to go also into the literature when deserved, and of course we can discuss later about the different techniques of the different approaches. So, about the preoperative management of the single suture craniosynostosis, for sure we perform in every case an assessment, a preoperative assessment of the psychomotor development of these children. This is one of our publications on this topic, where we presented the report about 200 children with a mean age of 42 months at the moment of the test. As you can see, I will focus on this talk mainly on scaphocephaly, plagiocephaly, and trigonocephaly, that all the patients nearly all the patients, of course, were in the normal range as far as the non-verbal, the language, and the general IQ was concerned, without significant differences or statistically significant differences in the three type of groups. A certain difference is present when we consider the visual development, because the flat orbit, the orbital hypoplasia, the head tilting in the unicoronal synostosis can affect the oculomotor behavior and the fix and follow. On the other hand, the fronto-orbital retrusion, the hypothalarism of the metopic synostosis will prevent the fixation shift and the visual field. And finally, namely the attention deficit more than the racing gaze defect will affect the fixation shift in children with sagittal synostosis. We perform, of course, also preoperative neuroimaging, especially CT scan in children with some finding that have been to check at CT scan, also MRI. Less frequently the ultrasounds, mainly to rule out some doubtful diagnosis at the beginning of the clinical history, and almost never the X-rays. The CT scan is, of course, useful to check also the minor sutures, such as you can see here, the frontostenoidal synostosis, and it's useful especially for the preoperative planning. Of course, the traditional planning with the 3D CT scan, but also to have the material for a 3D reconstruction of the skull of the baby, and for an adequate planning also for late cases like this one, where, of course, a systematic reconstruction of the facial skeleton is required. Of course, we use CT scan also for research, and for research was used at the beginning on also the black bone MRI. It is a valid surrogate of the CT scan, at least to rule out a differential diagnosis among the different craniosynostosis. We started using also the black bone MRI, but we use mainly the traditional MRI to rule out additional findings that we can find also in simple suture synostosis. For example, the hydrocephalus, actually the hydrocephalus is sporadic, as it happened in this case with post-hemorrhagic hydrocephalus compared with syndromic ones, and the Chiari malformation affect mainly children with lambdoid more than sagittal synostosis. What about the ultrasounds? For sure, they are useful. We mainly use for the differential diagnosis where required among the posterior positional and lambdoid synostosis. Of course, they have a role in the diagnosis of the synostosis, as demonstrated by several papers. Of course, we have just a couple of disadvantages as far as the visualization of the minor sutures is concerned, and also the poor sensibility in children older than 2 years. That's why, especially for the follow-up, we use the laser scan, and it's very easy to be used. Sometimes it's not so precise in spite of the good cooperation, apparently good cooperation of the baby. That's why we have just some scan also at the moment of the operation. This allowed to get some scan that is very useful for the post-op follow-up, as I will going to show at the end of this presentation. The most important part for neurosurgeons are the surgical management of the craniosynostosis. Those are the general principles that can be applied to the surgical management, that are the restore the spatial applications between the skull and the neurovascular structures, to further or to redirect the normal growth vectors of the skull, to correct the cosmetic impact, also the functional abnormalities is present, and to treat the possible associated impairment, for example, of the CSF dynamics. We can do it, of course, with an adequate intraoperative and postoperative team, namely the anesthesiologist, but also the scrub nurses, and for sure the intensive care unit. And if we look to the management of the sagittal craniosynostosis, we have some specific goals for this kind of synostosis, namely the reshaping of the cranial mold for cosmetical purpose, but to give space for the brain, making a biparietal expansion, and to relieve, of course, the bone constriction on the brain and the superior sagittal sinus. We have several techniques in the literature. As mentioned, I cannot address each of these in detail. I can show something about our past, about the personal technique. Now we are trying to perform a more extensive total bone remodeling for patients older than 6 months, but taking into account also these two additional goals that are to reduce the preoperative bleeding and decrease the impact of the surgical scar, we are in favor, whenever possible, of minimally-invasive technique. There are several of these that have been designed along the years in the literature. I like to remember here the one proposed more than 20 years ago by David Jimenez, who spent his life in the treatment of craniosynostosis and who unfortunately passed away 1 year ago, unexpectedly. And of course, his legacy is spread all around the world with the different techniques for the minimally-invasive management of this kind of craniosynostosis. Of course, in almost all the techniques, the use of postoperative helmet is required. That's why we try to simplify surgery with a more comfortable postoperative course. And it was the merit of my mentor, Professor Concezio Di Rocco, who designed 20 years ago this technique that is still a minimally-invasive technique that can be used safely and with good results until 4 or 5 months of age of these babies, without the need of the endoscope, but means without the mandatory need of the endoscope and with no postoperative end. We can scatter different small skin incisions along the calvarium of the baby, as you can see here, and may vary according to the characteristics of the baby. Sometimes we need only 2 skin linear incisions, sometimes we need 4 or 6. The principle is to realize a wide sinostectomy, 3 to 5 centimeters wide, and of course to reopen with large linear craniectomies along the corona and the lambdoid suture to perform a extraction of the bones and also a remodeling. Of course, if you need, you can put also the endoscope inside to check about possible bleeding or to dissect the periosteum or to remove the sutures, as it happens for the traditional, I would say, endoscopic strip craniectomies, but this is not mandatory. This was the study we published several years ago. Now we are working to the update of the study using not only the cephalic index, but also other parameters based on the laser scan. But at that time, we didn't notice any differences between the minimally-invasive group and the open group, considering of these comparable children, as far as the late cephalic index was concerned. This is an example of the immediate postoperative results, the early postoperative results, and the late postoperative results. No differences, as was mentioned, but 1/4 of the children, of the parents, the family of the patients operated on with the open technique complained about the surgical scar. Another advantage of the so-called invasive techniques was the minor duration of the surgical operation and the reduction of the hospital stay. Of course, we have also some evolution of these techniques, such as the screen-mediated distraction for the sagittal synostosis, or such an invasive treatment with osteogenic distraction for severe cases or for older children. What about the metopic craniosynostosis? The principles, the goal of the treatment in this case is to increase the volume of the anterior cranial fossa, to advance the supraorbital rim, to correct the hypothalarism, and to reshape the forehead and orbits. This is our technique, the auricular undulated skin incision, the pericranial flap, We perform a craniotomy by including the frontoparietal craniotomy, so behind the coronal suture, by including also the parietal bones. This was the traditional technique we used to perform the orbitotomy along the orbitozygomatic suture and the removal of the roof of the orbit in order to subluxate anterior to the orbit. Now we like using the piezo for this purpose. This is a fine instrument, like all the piezoelectric discs that allow us to perform the orbitotomy without significant bone loss, and we can use the piezo also for the contouring of the bone at the end of the operation. Of course, we have to reshape the frontal flap. Our technique is called shell technique, because we reshape like a shell, and then we put back the bone once the orbit has been fixed. We usually use resorbable plates for this. And finally, the pericranial flap suture. Those are some results in the early and late postoperative period. The trigonocephaly, for sure, is the craniosynostosis which rises more the imagination of neurosurgeons. So we can have the so-called Christmas tree technique, if you like, the cathedral dome technique, and of course also the frame-based cranial reconstruction. I will show the tool that we use for this purpose. But let's see something about the unicoronal synostosis. Here the goals are similar to the top synostosis, to reshape once again the forehead and the orbit, increase the volume at least of the ipsilateral anterior fossa in the orbit, and of course to redirect the vectors of growth of the skull. This is the most important point, since this kind of synostosis, you can see here, can involve the skull base much more than the other, especially the middle and the posterior fossa, much more than the other kind of synostosis. In less severe case, we used to do a trapezoidal craniotomy that is extended beyond the midline, and of course behind the involved coronal sutures, to perform the orbitotomy, as shown before, with a subluxation of the orbit, but also with a reshaping of the orbit. And then finally we use orbital plates to fix in overcorrection the subluxated orbit. Then we reshape once again the frontal bone flap, and we replace it in overcorrection to increase the chance, of course, of durability of the operation. This is an example of the early correction. On the late correction, sometimes such an overcorrection may persist over the time. When the cases are more severe, we use the frontoorbital bandeau for the correction. Once again, we use the piezo for the to obtain the bandeau. This was just to show you how easy to perform the also orbitozygomatic part of the drilling of the orbital roof. Of course, then we place back the bandeau and the orbital flap, and then the frontal flap. This is the tool that we have been using in the last 40 years for the frame-based reconstruction of the skull. Once again, we have different techniques also for the unicoronal sutures, including the mini-invasive techniques. Finally, I'm going to conclude about the postoperative management. Once again, we repropose the psychomotor development. This is the resource that we obtained after 10 years follow-up, and fortunately, we were able to detect that these babies had a normal neuropsychological as far as the psychomotor functions, the practical functions, the memory and executive functions, the reading and writing. In one word, the academic skills of these babies, of these children, were normal. The unicoronal group were in the low range, but always in the normal range. We found a 12% rate of persisting language phonological deficits, with no statistical difference among the three groups, but with the metopic group doing worse than the other two. And this is quite strange, but it is not so strange if we compare with the children without craniosynostosis with the same ages. We have 1/3 of the patients with some degree of attention deficit. That is a problem quite diffused today. And in this case, the sagittal group did worse than the unicoronal and metopic, but without statistically significant differences. The visual development in the children who were affected by a pre-op deficit, we can actually notice a significant and quick improvement in the postoperative period, with a progressive normalization for all the type of skills, and during the time with a quite good results after 1 year after surgery. Also, the cosmetic results are good. This is a mean about our experience and the literature that you can see here. For sure, the metopic synostosis seems to work better than the other synostosis, but the results are quite good. What is important, at least for us, is not to use CT scan or MRI routinely for the postoperative follow-up, because we prefer to follow the baby clinically. Of course, there is some reason to perform CT scan and MRI, we do it, but we prefer to use a clinical assessment for the follow-up, such as the Sloan class, and of course, the laser scan for the cosmetic. Let me spend the 2 minutes left to say something about the genetics. I will then put the genetics at the beginning of my presentation, since we, of course, use genetics to rule out syndromes, but of course, it is quite easy to perform a clinical diagnosis of syndromic craniosynostosis. So we use genetics routinely also in simple craniosynostosis, but mainly for research purpose. So far, we collected more than 1,000 cases to create a biobank to store the array, RNA, and the cells isolated from the blood and from the fetus that we take out during the operation to perform, of course, sometimes also in cooperation with the ERNM or the international vendors. One of the most important results that we obtained, this was about 15 years ago, was to actually demonstrate that the cranial suture are a sort of transient niche for the osteogenic precursors, which remains active not only during the prenatal full development, but also in the postnatal period. Another, maybe the most important result so far we obtained, is to differentiate the fusible suture between the open sutures. And actually, we found that the mesenchymal stromal cells from the fusible sutures maintain an hyperosteogenic phenotype during the activity during the development of the baby. And especially, we found an overexpression of BDS9 gene that is involved in the primary cilium activity, that is important for the development of craniofacial skeleton, and a downregulation of the axin-2 genes that is important for the morphology of the craniofacial skeleton. This was why I was mentioning before. We extended the panel of 53 genes for the next generation sequencing, and we are adding new genes to our panel for the diagnosis, for the research on the diagnosis of this craniosynostosis. And finally, our final purpose will be to develop a new technology for a targeted track tech. I will leave you with this last slide. I cannot avoid mentioning the artificial intelligence. And I don't know what will be our future. For sure, the diagnosis of the craniosynostosis will be done with the artificial intelligence, just with a scan. We can put the baby below, and finally, the computer will give us the diagnosis. I know that this seminar is registered for the ISPN library, so I invite all of you to contribute to this project. Thank you for your attention.
Thank you very much, Luca, for this very complete presentation. It was a very hard task to summarize all the simple synostosis in a very short time, but Alison has a quite similar impossible task to summarize all the complex one, also in a short period. Thank you, Alison, and thank you for being with us.
Thanks, Federico. I also agree that it's very difficult to really cover all of the techniques. So I've taken a slightly different approach, and I'm going to talk about the principles of management. So really focusing on the things that you should be thinking about and what things are driving the decision making that you are going through with these cases. You'll have heard from Luca's talk that there are lots of different techniques for managing craniosynostosis, and every group will have a slightly different technique. And when you're in a situation where you have lots of techniques, the answer to that is that there is no perfect technique, but there are lots of good techniques. So generally in syndromic synostosis, you can use those good techniques that you have and that you're comfortable with from your simple craniosynostosis cases. What is different, though, is the extracranial complications, the extracranial disease associated with it, and the impact of the craniosynostosis on the development of the brain and of the face. And those factors that you have to take into account. And in particular, we're often struggling with the problems of Chiari and syrinx, raised pressure, and hydrocephalus, which are much more frequent with syndromic synostosis than with single suture. So really, we have to come into it with a different mindset. When we meet families, they are often looking for an operation that's going to fix the problem, so a one and done solution. And this is often the case that we can do this for a single suture craniosynostosis. But when we're dealing with syndromic craniosynostosis, we need to be very upfront with the families about the fact that it's not going to be a one and done, that it's going to be a journey with timed and staged interventions that relate to the growth, both of the brain, of the cranium, and also the face, with different interventions at different times for that. We are more often dealing with wanting to make a functional correction much more than a cosmetic correction, and will prioritize function and brain growth over the cosmesis, particularly in the first year or so of life. For me, the volume of the cranium is probably the most important factor, and that most of these children, even if they are born with macrocephaly, will go on to have craniocephalo disproportion. And so maintaining volume and not losing volume to get a cosmetic correction early on is very important. We have to time our interventions to the growth, and we had a beautiful introduction from Federico about the different stages of growth that the skull and the face go through, and how we have to address that in planning our approach. And I also acknowledge that in many of the countries and regions that you might be working in, this is particularly difficult when you've got limited resources, where a one and done solution is not only what the families are looking for, but also what our healthcare services might be able to provide. So something that has multiple interventions and prolonged care can be much more difficult to provide. Also, as I alluded to, extracranial management is very important, and it's often the first things we're doing in looking after these children. Many of the syndromic children will have problems with their airways, be it choanal atresia, be it problems with their trachea and the cartilages. And often the first interventions that we're doing is about establishing a secure airway. We've tried to move away from tracheostomies in these children with time. However, there's still a moderate proportion of children with syndromic craniosynostosis that will need to have a tracheostomy until they get to the point where their midface can either be surgically managed or has grown enough to allow them to have a patent and competent airway of their own. The eyes are also very important, and we need to think about the orbital volume. We need to think about the eye health of the cornea, and also from a pressure viewpoint, the health of the fundi as well. The feeding and nutrition is also very important, not just for general growth and development, but also for bone and brain growth and development. And also in a number of the cases, there can be spinal anomalies that are associated. And you would have seen in Ron's presentation with the child with encephaloceal that child also had a basilar invagination. And it's not uncommon that there are associated craniocervical junction anomalies and cervical spine anomalies that we also have to take into account in terms of our timing of what we're doing surgically. So starting to think about Chiari and syrinx and craniosynostosis, this is a complication that we see both in single and multi-suture synostosis, but it is much more common in multi-suture or syndromic craniosynostosis. And we see it in up to 70% of cruisons, which, as you know, is a balanced pan-synostosis. So they have a reasonably good head shape, but they have significant craniocervical disproportion, and a Chiari is very common. And then in over half of the FIFers as well will have problems with Chiari and syrinx. I think that when we start to think about how we manage a Chiari, it's important that we don't consider them in the same way that we consider Chiaris that idiopathic Chiaris or Chiaris from other primary pathologies, because these Chiaris really relate to what's happening with the sutures and the growth. And so it's important to think about what is the driver of the Chiari and what is the pathology that is driving it. Because in some cases, it may be that we can actually correct that pathology in the first instance. So if it's craniocerebral disproportion, if the skull is just too small for the brain contents because all of the sutures are fused, then an operation that is directed at increasing the volume of the skull is our logical first step. If it's underdeveloped posterior fossa, particularly in the case of bilateral lambdoid synostosis, then again, we want to look at an operation that's going to increase our posterior fossa volume. And often a posterior vault distraction is the best, in my opinion, is the best way of achieving that. But other operations, again, directed at increasing the volume of the posterior fossa will give you the same outcome. However, in many cases, it's the skull base anomalies that are driving the Chiari, and that is a little harder for us to deal with and to treat. There's also secondary Chiari that we can see in craniosynostosis, and that's from hydrocephalus and from all the various ways that we can get hydrocephalus with sutural synostosis. And if our primary driver is hydrocephalus, then we have to consider whether the management of hydrocephalus is our best first step in treating the Chiari. So our options for managing the Chiari, firstly, craniofacial correction, particularly if there is a degree of disproportion. So if we look at the effect of managing the craniosynostosis alone, so this is a series that looked at total vaults without a posterior fossa decompression in children that had a Chiari malformation prior to their surgery. And you can see that in all cases, the tonsillar herniation was either improved or stable. So there's certainly some evidence that dealing with the cranial volume can help in many cases to manage the Chiari. Traditionally, neurosurgeons tend to think about a posterior fossa decompression when we see a Chiari malformation. However, and we spend a lot of time then arguing about how we do that, whether that's bone only, whether we do a duroplasty, whether we add on a cervical laminectomy, if the tonsils are very low, and the risks that come with that of instability. However, it's interesting that in the setting of Chiari malformation with frontal pathology, such as a bicoronal synostosis, historically we've seen craniofacial surgeons addressing the pathology that they know, which is the coronal synostosis. And so there are cases where they've had multiple redo bifrontal orbital advances to try and affect the problems that they were having essentially from the Chiari malformation. And that wasn't necessarily as effective because although the pathology appears to be coming anteriorly from the coronal sutures, it's really the effect on the cranial volume that is the problem, and the effect of that is posteriorly. Shunting the hydrocephalus is one option, certainly if there's significant hydrocephalus, but as I'll get to later, there is a cost associated with doing that. And really, more and more, we're tending towards going towards posterior vault distraction to manage the Chiaris when there is craniocephalodysproportion. And if you think about that and look at the issues that we have there with craniocephalal disproportion, small posterior fossa, skull base anomalies, and hydrocephalus, the different operations that we do will address these to different measures. So a craniofacial reconstruction will improve the disproportion. It might help the small posterior fossa. It's generally not going to change the skull base anomalies, and it might be helpful for the hydrocephalus. A posterior fossa decompression won't change the disproportion issues, but it will help the small posterior fossa, and it might help the hydrocephalus by re-establishing CSF flow around the craniocervical junction, and it won't impact upon the skull base anomalies. If we work on, particularly in bicoronal synostosis, on redo BFOA or calvareal augmentation anteriorly, we do get some increase of the cranial volume, although the magnitude of that is much less than if we do a posterior distraction. It doesn't affect the posterior fossa, doesn't help the skull base anomalies, and might help with the hydrocephalus. A VP shunt only helps with the hydrocephalus and doesn't address any of the other issues. And really, the reason why many of us have turned towards posterior vault distraction in this case is that it actually affects many of the components that are causing the Chiari. So it will increase the volume. It will address the small posterior fossa, particularly if you take your bottom cuts low enough. It will often help the hydrocephalus. And interestingly, there's now several good studies that show that there is significant improvement in the skull base anomalies associated with posterior distraction, and postulation that it is the pulsed tensile forces that occur across the skull base from the winding of the distractors that actually encourages some skull base growth. So if we think about hydrocephalus and craniosynostosis, it occurs in about 8% of all children with craniostosis, but is much more higher in syndromic cases. It is most likely to occur in Crouzons and cloverleaf Pfeiffers, and really that makes sense because those are the children that have the most significant cranial vault restriction. It's important to remember that with APERTs that it is often seen that there is a non-progressive ventricular megaly. So perhaps those children are the one that you should watch and wait initially and monitor rather than leaping in to do a shunt in the first instance. Again, when you're thinking about how to manage the hydrocephalus, I have a bias in that I try to avoid shunting if I can. And so my thought processes are always around why has this child got hydrocephalus? And what are the features of their syndromic craniosynostosis that is causing the CSF circulation disorder? Now, often that is venous hypertension secondary to the skull base anomalies. And to date, we don't have a number of good treatment options for the skull base anomalies, except perhaps for posterior vault distraction. But it can also be a secondary hydrocephalus, either from obstruction of CSF flow, which occurs at the foramen magnum, or it may be simply because of the Chiari malformation plugging the foramen magnum, or because of the very small size of the posterior fossa. So the management options that we have, if we think it's cranial-caudal calvareal restriction that's the problem, then a calvareal expansion is a very good first option. And certainly, if we look at older children who develop late problems with hydrocephalus or with pressure, then if we can show that they've actually had skull vault restriction, then a calvareal expansion is often a good first option. The CSF diversion, again, is something that we're all very familiar with. And in many cases, if we think it's forced ventricular outflow that's the problem, an ETV may be a much more sensible option than putting in a shunt. And I will come on to why I am so negative about shunts and craniosynostosis in a little while. In the past, people have tried to address the issue the venous hypertension from skull-base anomalies by looking at venous bypass. However, there were very few successes with this and a significant high failure rate, so that's really gone out of favor at this point. And this is just a nice algorithm that tries to address how you think about hydrocephalus and craniosynostosis with children, really dividing down into whether you go into the cranial expansion or the CSF diversion, and looking to see whether you can try and manage the hydrocephalus with one procedure and avoiding a second procedure. And again, the other thing to think about when you're looking at this is the child clinically stable, and do you have time to plan a calvary expansion surgery and have a slower improvement in the CSF circulation, or is the child decompensating and really needs CSF diversion as their first procedure? And unfortunately, sometimes we are forced into this by the nature of the disease itself. So why have I said miserable things about shunts, and why am I very negative about shunts? The main reason is that differential pressure valves really work against everything that we're trying to do in craniosynostosis surgery. So mostly what we're trying to do is we're trying to expand the calvarium, particularly in syndromic cases. And what a shunt does is that it has negative pressures that work against the positive forces that we need to actually expand out to the skull. And you will have seen nicely from what Federico presented in his first talk is that those positive forces of the brain pushing out against the skull are very important for the skull growth. And if you have a shunt which dampens those down with its negative forces, it certainly has a big impact. And you will have all seen cases of over-shunting and secondary synostosis in a relationship to over-shunting. Whilst I often don't use programmable shunts, I think craniofacial and particularly syndromic children may be a good indication for a programmable shunt, especially those who have a virtual off, so that you can actually modulate how much the shunt is working around times that you're trying to expand the skull vault. And then, of course, shunts, as we all know, introduce more morbidity for the child with both malfunction and with infections. So looking at raised pressure in craniosynostosis, we know that it occurs up to 17% of single suture synostosis, but is really much more prevalent with syndromic and multi-suture synostosis. So much more of the equation and what we're trying to work out as a solution for these children. So again, it's helpful to think about what is driving the problem with raised pressure. Is it simply that the skull vault is too small for the size of the brain? Is it that venous hypertension, secondary to the skull base changes and stenosis at the outflow, that is causing the raised pressure? Is it in fact that we haven't been doing very well with their airway and they've got significant OSA, and we need to think about their airway or CPAP or something to improve that side of the equation? And then, of course, hydrocephalus and obstruction of CSF flow at the foramen of magnum is another important driver. And thinking about this and identifying helps to clarify the ways in which we might address this for each child. The assessment of intracranial pressure in children with craniosynostosis is really a three-pronged approach. There's the clinical suspicion from headache, behavioural change, and often subtle neurocognitive deterioration, particularly in the older child that you're following. In a younger child, poor head growth can also be a good indicator. Examination can be helpful, particularly in the younger child with a full fontanelle or increasing bony defects. And papilledema, when present, is very helpful, but when absent is not so helpful, and that a number of children will not show papilledema below the age of 2 years of age, and even after 2 years of age, up to 10% will not have a communication with the CSF along the optic nerve sheath, and so the absence can be falsely reassuring. The other thing that we sometimes struggle with is the number of children who subsequently are called to have drusen when we've actually done intracranial pressure monitoring based upon concerns of the fundus. A lot of people want to leap on and do a scan when we have questions about raised intracranial pressure. And the difficulty is that there's nothing that is absolutely diagnostic about pressure on a scan, and that all of the findings are subjective and suggestive. And these findings are things such as small compressed ventricles with loss of subarachnoid spaces, the appearance of copper beating or fingerprinting of the inner table of the skull, the distended optic nerve sheaths, and the elevated discs. What is perhaps looking as if it's going to be more helpful is the use of OCT, and that's becoming more of a standardized assessment, looking at the retinal nerve layer thickness and inferring pressure effects on that. Lumbar punctures I have never found to be particularly helpful, and there's always the argument as to whether if you do it with sedation, you affect their respiration, which then in turn affects the intracranial pressures. If you do it with a light general anesthesia, then likewise the anaesthetists usually run them with their CO2 being a little bit higher, which again affects the pressures. And if you do it without appropriate analgesia, you have a very unhappy, anxious child, which again affects the pressures. So I haven't found lumbar punctures as single measures to be that helpful. Visual evoked potentials in the research domain have good correlation, but they seem to be quite impractical for rolling out and managing in a young population. TCDs are being assessed in some units and showing some promise, but really the gold standard for assessing pressure remains ICP monitoring. So, management options in syndromic craniosynostosis, and I have to say that this is very much my bias, and you probably will have a number of different options from different surgeons, all of which are equally useful. My bias is really to look at calvarial expansion in the first instance and the multiple versions thereof. So really trying to address the issue by allowing positive forces to have an effect. And I'd say that shunt at your peril because of the role that negative forces can have on the skull growth and on what you're trying to achieve with the volume and syndromic craniosynostosis. And so they're coming back to this table again, looking at what the effect of these different operations have on raised intracranial pressure. And again, posterior vault distraction comes out to be a very good operation for children with syndromic craniosynostosis, as it addresses both the raised intracranial pressure, hydrocephalus, and the Chiari. So to try and bring this all together, I've tried to illustrate it with some cases so that it becomes practical rather than theoretical. And this is a young girl who had a fetal diagnosis of Apers syndrome with all of the typical facial and skull changes that are associated with that. She had shallow orbits with quite protuberant eyes. Her airways were very restricted, and her initial management really associated around trying to get a safe airway for her, which resulted eventually in her having a tracheostomy in the first couple of weeks of her life. There is often an intellectual impact associated with this, which at this first presentation is difficult to assess. She did have associated syndactyly. There are dental and palatal changes associated with it, and often cardiac issues as well. This is her first CT scan, and you can see the very characteristic features with the head shape that is very restricted around the sphenoid wings. That's giving almost the trefoil shape or cloverleaf shape to the head. The significant pressure effects on the bone, the very wide metopic suture and fontanelle, and the very underdeveloped face and misdeveloped and shallow orbits. However, at this point, you could see some of the other features when you looked at the MRI scan, that she has a low torcular, a very small posterior fossa, although at this point does not have issues with a Chiari. She has a very misshapen brain that is growing to the restriction that the craniosynostosis is providing. And there's already some changes occurring in her venous outflow and venous sinuses. However, at this stage, she did not have signs of hydrocephalus. and we felt that we were able to give her some time to grow before we undertook anything for her beyond management of the orbits and of her airways. She lived in Darwin, which for those of you who are not familiar with Australian geography is about a 4 to 5 hour flight away from us in Melbourne. And she was a 4-hour drive from Darwin, where they lived rurally. So it's very difficult to manage a patient that's this complex, that is that far from specialist care. And once she was stabilized and went home at 4 weeks of age, she unfortunately developed a globe dislocation at 6 weeks of age. And I want to thank the family for being generous enough to allow me to show these identifiable pictures so that you can really understand what a globe dislocation looks like. And looking at the ophthalmic surgeon's fingers there, see how incredibly shallow those orbits are as you see him identifying the bony margins and really understanding why there's really very little room for the orbits, for the globe, and why they so frequently dislocate. So this was managed with a tarsorrhaphy. At 6 weeks of age, when she came back with that, we also took the opportunity to do a CT scan. And you can see now that the picture is quite different. So in those 4 weeks between her original scan and the scan, she's developed significant hydrocephalus, I think, from the combination of initially venous hypertension. And now you can see she's also got foramen magnum plugging, she's got a Chiari, she's got fourth ventricular outflow obstruction, she's got basilar invagination, and she's got significant thumb printing and indentation through the pressure. Having been very, very negative about managing, about shunts, there are times when you do need them to manage a decompensating patient, and I thought that this was a case in which we did need to do that, and so I placed a shunt for her. The question then becomes, what sort of shunt do you place? And I believe strongly that a flow-controlled shunt probably allows you the best gentle control of her hydrocephalus, unless you're going to go for a programmable shunt. So she had a flow-controlled shunt placed for that, which you can see there. Interestingly, though, she went back to Darwin, which does have some neurosurgical services for adults, but not necessarily pediatric neurosurgical services. And she developed some vomiting, was seen at a local hospital, and at the time point of the arrow there, you can see that's where they did a shunt revision, and they changed her from her OSV shunt to a low-medium pressure differential valve shunt. And you can see the significant effect that that's had on her head circumference. And this is what I mean about the problems with the negative forces associated with the shunt, with the significant head drop that was associated with that. Unfortunately, she had, despite having had tarsorrhaphies, her shallow orbits were still problematic, and she had another dislocated unreducible globe with another emergency evacuation down to us for the ophthalmic surgeons to fix that. But fortunately that did quite well. And at that point, while she was with us, it gave us an opportunity to think about what we were going to do with addressing the vault. And you can see there, she has got significant underdevelopment of the frontal areas, as well as all of the other abnormalities that we talked about previously. And so our first thought in managing with this, despite the fact that I've advocated clearly for going to the back, was actually to see whether we could address this from the front, simply because we didn't really want to interfere with her shunt. And she had a bifrontal orbital advancement in the first instance, and you can see the fairly typical construct associated with that, and still some signs of pressure at the back. Again, she had another shunt revision in Darwin. Again, they changed her valve down, and you can see that with overdrainage with a shunt, her ventricles have disappeared. At 12 months, she was showing some signs of her head growth stagnating, and she was getting worsening venous collaterals. And so that was the time that we thought that we needed to distract her. And the question then becomes, how do you manage a shunt when you're trying to distract them. And so what we've done in this case is that we've changed her valve for a programmable valve which has a virtual off. We've turned the valve off as we've tried to distract her and allowed her ventricles to come up so that she has filled into the space as we have distracted her. Again, however, she went back to Darwin and had a shunt revision, and I think the picture on the right really shows the negative effect, and you can see how much she's collapsed with her ventricles when she has a differential pressure valve in there. She's gone on to have significant problems with her skull base. So as much as we've tried to address the cranium, her venous outflow issues are progressive. And at the moment, those are the difficulties and challenges that we're dealing with. But fortunately, she seems to be developing some native collaterals, and her head is growing reasonably well now. The next case I'll go through quickly because I think I'm over time. But this was a boy who was born with a severely brachycephalic head with significant pressure and marked neurological delay with no visual fixation at 5 months of age. And his problem was complicated by the fact that he had non-compaction cardiomyopathy, which limited our ability to operate on this child. And so we went through the options and decided that a shunt was not going to help him, but we needed to make room and buy time. And so that's where it's useful to have lots of different techniques that you can use. And so the most non-invasive technique that didn't have him prone, because the anaesthetist wouldn't let us put him prone, was to just put some springs in and buy some time. And that was a very effective technique for this young boy. And then going on to other techniques, was this young child who was the child of a previous Sacher-Chopson family of ours. And you can see this very unusual head shape at 2 weeks of age with a child that had significant raised pressure that was decompensating from that. At 2 weeks of age, no one really wants to undertake a big cranial reconstruction. And so what we did was really use one of Harvey Cushing's techniques where we took off all of that frontal bone and discarded it. So we relied on the osteogenic potential of the native dura and the periosteum that you heard about previously to allow that brain to re-expand and then to ossify. And this is what you could see in 4 months' time, that the brain had re-expanded into the room that we had made and had started to ossify and allowed us to do a more standard bifrontal orbital advancement when the child was at a more appropriate age. So the key points is that volume is very important and that you must never lose volume in the early years to improve cosmesis. That cosmesis may be something that you need to address later after more growth has occurred. Always remember that we work on the vault, but most of our thinking must be happening about what's happening at the skull base. And what we really need to do with our research in this is to find better ways to address the skull base. A venous outflow must always be part of the equation, and shunt at your peril. Thank you.
Thank you very much, Alison. Very nice report and summary of all the different techniques and very challenging cases. For the sake of time, I'm going to move to Suchan and have all the questions at the end, if you can still be with us. Suchan, you have 15 minutes. Thank you.
Just a moment. Let me screen. You are seeing my screen?
Can you put in presenter mode?
Yes, yes.
Okay. Okay. Good evening, everyone. Since I'm the last batsman of the last session, of the last webinar of this year academic year, I take this opportunity to thank Jeffrey and Arthur for not only for giving me this opportunity here, but also for carrying a wonderful academic year with so many webinars, debates, physical CMEs. Thank you, Education Committee, Jeffrey and Arthur, for this marvelous job. So today I have to speak on fibrous dysplasia and other anomalies. So this is not really talked about much, and because, you know, all of us doesn't have much of experience, I believe. I mean, we get anecdotal cases now and then, and so I thought I'll be speaking about this. So fibrous dysplasia is a non-malignant condition in which normal bone and marrow are replaced by fibrous tissue and unevenly distributed open bone. There are two varieties, mainly monostotic and polyostotic, where there is one involvement of bone, and polyostotic, where there are multiple bones involved. Or it can be associated with McCune-Albright syndrome called MAS, triad of polyostotic fibrous dysplasia with Cafaleau skin macules and endocrinopathies, most commonly associated with precocious puberty. So there is a genetic attribution to this condition. So there is seen that there is a somatic mutation in the alpha subunit of the stimulatory G protein encoded by the gene S at chromosome 20, and the mutation in this gene results in dysregulated G alpha S protein, signaling an elevation of cyclic adenosine monophosphate in affected tissues. Monostotic fibrous dysplasia and FT are mostly 70 to 80% and is more common than polyostotic. Craniofacial areas in the most common site of fibrous dysplasia. So if you look at it, it is monostotic or polyostotic. And in this, craniofacial is only 10 to 25%. In monostotic variety, polyostotic is most in 50 to 90% in the craniofacial variety. And the most common craniofacial bone involved is maxilla or the zygomaticomaxillary complex, then followed by mandible. Then comes the frontal sphenoidal ethmoidal, where the neurosurgeons come into picture along with the ENT specialists, and then of course the parietal, temporal, and occipital bones, where only the polyostotic variety are associated with various syndromes where only lesions are there. Lesions syndrome. When it is associated with skin lesions and hyperfunctioning endocrinopathies, then you have the McCune-Albright syndrome. And when you have intramuscular myxomas associated with the PFTs, you have the Mazabrod syndrome. So what are the extraskeletal manifestations of FT? They are usually Cafaleau spots, endocrinopathies, as I have already said, precocious puberty, most common presentation in girls, in testicular abnormalities, in 85% of boys and men, others, hypothyroidism, growth hormone excess, and neonatal hypercortisolism. Growth hormone excess is an important contributor to morbidity in patients with craniofacial FTs and is associated with the optic neuropathy and hearing. Malignancy may be associated secondarily with FT and McCune-Albright syndrome, where they are usually osteosarcoma, fibrous dysplasias transforming into malignancy is extremely rare, and it is less than 1%. So this is a typical appearance of a Cafaleau spots. You can see they're not like the typical neurofibromas. They have a jagged and ragged in the scalp. So this feature of craniofacial dysplasia, of the sphenoid bone, where you can prominent situated osteoclasts. You can see these are the osteoclasts, and this is from a maxilla, the same thing, where you can see irregular osteoclasts here and there. So what are the radiological evaluation you need to do? You need to do an X-ray, you need to do a CT, you can do an MRI to rule out other bone scintigraphy. The bone scan usually shows hyperactive or increased intake of dyes in case of fibrous dysplasia. And there are different types of FDs: sclerotic form, that is bone expansion and homogeneous radio intensity on CT, vegetoid or mixed subtype of bone expansion and alternate areas of radio density, and the cystic time, where CT shows lucent lesions with sclerotic border. usually it is surgical, but medical management also there, and usually they are used by the orthopedic surgeons where the long bones are involved, and what is given is biphosphonates, where an anti-resorptive agents that decrease bone turnover by inhibiting osteoclasts. Alendronate, pamidronate, zolendronate, and etidronate are all used, and people have also tried, but then excess of everything is bad, and they do have the side effects. They also have donizumab. Some people have tried, but the orthopedic because fibrous dysplasia are also known to have with a rise in interval. So because that inhibits that, that's why they have some studies have that they have shown some results with this. But however, they have also said that when using those drugs, there are complications like OGN, that is necrosis of the jawbone and all. So this is not very well established, but yes, and for bone pain and all, these drugs may be used. However, to monitor the disease progression and the response to non-surgical treatment, the routine evaluation of serum alkaline phosphatase level is done. It's not symptomatic. You may just follow the cases and again, since it is because nobody what interval you need to survey, you need to do the surveillance. Some people do it 6 months, some people do it 1 year. So associated
I think we have an audio problem, Suchanda. So unfortunately, the connection went out while discussing this management. I don't know, Linda, if you have any solution. Oh, Suchanda is back.
sorry, I'm so sorry. There's a storm outside, and I think
Okay.
Okay. Just talking.
I think we have a problem with the connection. Linda, do you have any backup solution to propose? If we cannot finish the talk, we're very sorry, Suchanda. I'm sure that Arthur and Jeffrey will manage to prepare a webinar only for you in order to present the talk. Just one quick question. So for you, do you have I don't see any question and answers, so I think that most of the questions were already answered while presenting, or everything was so clear that we don't have any more questions. Maybe we can just address in the few minutes we have left. If Jeffrey, you mentioned the problem of the venous return and the venous anomalies. I don't know if this was your question, because we all know that in this in the synostosis we have this problem. So, Alison, do you think that the management with the distraction or the shunt can increase improve the venous return, or do you do a specific management for that?
I wish I had a specific management. I think the distraction probably does help. But I don't have enough apart from a couple of anecdotes to prove that. And it's certainly something that I think is the natural flow on from the studies that people have done looking at the skull-based changes. In reality, we often watch and wait and they develop helpful collaterals, and then it's about making sure that we don't interrupt those collaterals. And really, I think what that translates to me is that if you do have a child who has got either basilar invagination and normal cervical spine or severe Chiari, and they're syndromic and you're worried about their venous outflow, you might actually need to be more proactive and operate on that before they develop those large midline venous collaterals. Because we've certainly had a few children we've inherited later that have got very established flow where most of their outflow goes down the back of their neck, and we haven't actually been able to safely address any problems with the posterior fossa or the upper cervical spine because of the risk of interrupting that outflow.
Yeah, the interruption of the flow can be a catastrophe.
Yes.
So, Chana, you're back, so maybe you can continue.
Yeah, I'll just go quickly because there's a lot of wind there, and I think that's the reason why it's getting disconnected. Anyway, I was in the management part. So for the management part, if there is aesthetic, then we wait till this one subsides and becomes stabilized, which usually happens by 15 to 18 years of age. And for the peak time of fibrous dysplasia manifesting is around what you call 5 to 7 years, and by 15 to 18 years stabilized. So it is usually better you do it after 15 years if you are only correcting for aesthetic reason. But then at times there could be some emergency situation like sudden visual loss or progressive visual loss or hearing loss if it is in the temporal bones and involving the skull. At that time, the surgery is required in the short term. But it's never a case where, you have to do an immediately emergency surgery, except that if there is some associated fibrous dysplasias are known, especially the sphenoethmoidal ones are known to be associated with aneurysmal bone cyst, and at times they may bleed and they cause an acute compression on the optic canal, and that is the time only when there can be a very rare incidence where you might have to decompress the optic nerve. Radical excision is best, but mostly not possible to prevent recurrence. Regrowth occurs in up to 50% of the patients receiving partial removal. So if you can remove radically, then that is the best. Then there are these two zones which are being the Chen and Kim. They have described the zones of fibrous dysplasia. Zone 1, you can see this is the zone 1, and this is the zone 2, and this is the zone 2, and this is the zone 3, and this is the zone 4. Then in the zone 1, when it is orbital or zygomatic or maxillary bones, excision is the complete excision and reconstruction can be done. If it is zone 2, then of course you can either wait and watch as I have shown or done a radical resection. If it is zone 3, where again the petrous bone and all those things are involved, where all the major blood vessels, venous structures, everything is there, then only surgery for symptomatic cases. I would like to bring to your notice that even if the optic canal are very compromised, it is not recommended to actually de-roof the optic canal, because in most of the studies they have seen that even if the vision remains stable, even if the canal is quite narrow, and you actually do not need to go and de-roof prophylactically unless there is a very pressing indication to have for the vision to get improved. Otherwise, you should not mess up with the optic canal, because most of the time it has seen that the prognostically the vision is worsened after doing such a procedure. And in zone 4, again, 4A, maxillary alveolus and mandible, all those things are there where you can do either a recontouring or a conservative management as decided. But those are the areas which the plastic surgeons come into the picture. So next is radiotherapy. What is the role of radiotherapy? The role of radiotherapy is strongly contraindicated because it is not radiosensitive and it is very negative for the growth centers, effects on the growth center in young parents. And also it is seen that there is a risk of sarcomatous transformation. So these are a few examples which I'll show. This is a simple monostotic type. In fact, it is not monostotic. It is a polyostotic type where more than 2 bones are involved, where you can see it is a solid type. There is no cystic. What you need to do is you to excise the whole. You take a big flap and then you excise the whole thing. This is how the oven bones look like. They definitely look different from the normal cortical bones, and it's a time taking. You need to be very patient to take them out. Some people just shave and keep it, but it's always better to replace the whole bone with a healthy margin and replace it with either a split graft from the opposite side, or you put a titanium mesh, whatever. But then the margins are not actually very well demarcated, though it is seen here. You don't know till what level inside it is spreading, that oven bone. So it is better to take a sufficient margin around and then replace it. So this is another case of an esophageal type of fibrous dysplasia. This was a 7-year-old boy who presented with proptosis and stuffiness in the nose. So this required this was a case in 2010. And at that time, we did not have an endoscope. Today, I think we would have explored it with an endoscope. And then, so we did a bicoronal flap in this case. This was quite a big lesion, but then you can see inside it is all soft because it is open bones there. And with the help of plastic surgeons, just like Ron has shown for encapsulocele, we have used the same approach. We have gone in, we have taken out, and after that, we got a very good result. But then that was not the end of the story. 2 years post-op, he again had to undergo surgery for ethmoidal resection and by an ENT surgeon. And 6 years later, he again had an infection because the plate and screws what we put there, they got infected and we had to remove it. But we just removed it. We did not remove the bone and all, and it's fine. And now I think last 3 years back, we had a follow-up with him and he is doing well. He's in some sort of a mechanical engineering course. After that, I don't have any follow-up of this child. And this is another boy, which I would like to show that he presented with visual disturbances. But then this was picked up by a teacher in school. They are so subtle and progress insidiously that they actually miss out. And the teacher picked up the school. But when he came, he had bilateral optic atrophy, squint and scapulocephali along with that. And these were the pictures where you can see this type. They were all compressing the optic nerve. Here, optic nerve here, there, here we went in and we, of course, deroofed the optic nerve. Thankfully, we did not have any problem with this child and he did well. He did well. His vision did not improve much, but he was able to manage to see with one eye at 3 meters and the other eye was, PL was negative before, but then after 6 months, there was just a PL positive in the left eye. So that much we could achieve with this, and then he remained stable from there on. Now in this connection, I'd like to say I had another experience with a 15-year-old boy where we went in and we actually deroofed the optic canal because he was having a problem. But that is what I want to say, that we burned our hands. I could not bring the pictures because I could not retrieve them. That was in 2014. And then the optic nerve, he did not have any visual problem, but we deroofed the optic canal because it was very narrow and we burnt our fingers and the child became blind. And we really ended up, until now, we feel guilty about that particular case. So, and then when we went through the literature, we found that it is advised not to do on a prophylactic basis. So this is another case very recent, this year only. And she was an 18-year-old girl, and you can see this, this was sitting in the sphenoid sinus and the ethmoid bones. So she just presented with headache, but because she was also sometimes complaining of nasal obstruction, and we know that this might have stabilized at 18 years of age, we went in ahead, and when we just needed to go transnasal transsphenoidal approach, what you do for pituitary, and we just need to use the drill and drill out all this. And this is what, yes, this is just the anatomical diagram. I did not put the video purposefully. And this is all these bones can be taken out with patients, and everything can be removed. And this is the post-op scan you can see. And the whole thing has been removed, and she is doing fine. So besides that, I have also been asked not to, we have to speak about certain bony lesions. They are not life-threatening usually, and hence underreported and delayed reported. They're relatively rare. Skull lesions in the pediatric population are common entities and often constitute diagnostic dilemma. In the neonates and infants, congenital and benign lesions are more prevalent, whereas in older children, neoplastic and inflammatory are more common. So what are the different, if you look, always a request role, so I'll just go very fast among them. That could be either decreased density or increased density. Again, it could be generalized to localized. There could be variations in the skull size. It could be micro or macrocephaly. There could be abnormal head shape, already discussed, calvarial defects or acquired conditions, post-traumatic or neoplasia. So if you look at the density problems, generalized, it could be osteogenesis imperfecta, achondrogenesis, hypophosphatemia, or Menkes syndrome. In decreased localized, it could be a lacunar skull. In skull density, it could be osteopetrosis or pycnodystosis, craniofacial dysplasia, or they are all very rare, but then for the completion, I'm trying to mention all of them. In localized, it could be frontometaphyseal dysplasia, craniometaphyseal dysplasia. So skull size, it could be macrocephaly. You know, macrocephaly occurs in trisomy 21, 13, severe hypoxic ischemic injury, fetal alcohol syndrome, Torch syndrome, Rubinstein-Tabby, and Zika virus infection. Macrocephaly, hydrocephalus, subdural fluid neurofibromatosis, achondroplasia, tuberous sclerosis, or various other metabolic storage disorders. This is an example of a microcephaly where you can see the typical head size and how it happens in microcephaly. But they're very rare, 2 to 12 cases per 10,000 live births. Macrocephaly, this is a case of a hydrocephalus where you can see in the translumination, the whole venous system is seen. So you can get macrocephaly like this and various other things. Abnormalities of head shape, you can get faulty fetal packing, positional plagio, craniosynostosis, faulty fetal packing. Then this is positional plagiocephaly. I will not talk about craniosynostosis, completely discussed here. Calvarial defects, you can have burr holes, parietal foraminus, large fontanalis, neurofibromatosis, Langerhans, crania bifidum, leptomeningeal cyst, and osteomyelitis. This is aplasia cutis, where you can see there is no skin and subcutaneous tissue, and the brain may be seen or the bone may be seen. So there are various things which can happen with aplasia cutis. And these are the whole list of things for interest you can get in any literature, any pediatric textbook. A lot of syndromes are, this itself is a book by itself, and a lot of things are maybe associated with aplasia cutis. Anencephaly, were already mentioned, there is no other outer lining other than the brain is completely exposed. And then this is bilateral parietal foramina, where you can see here, these are the holes. They look like burr holes, but there are congenital defects. These are the arachnoid granulations. These are the Langerhans cystocytosis. These are examples of sinus pericranii. Again, neurofibromatosis, they can present with sphenoid wing dysplasia. This was a case which we have seen, and here you can see there is the sphenoid bone is missing here. This is a case of neurofibromatosis where you can have this sort of anomalies. The plastic surgeons usually come to help us and reconstruct the bone. Sometimes you can take a bone from the iliac bone or the femur and then reconstruct it, or you can take a titanium mesh and reconstruct it. But however, in this case, we could not do, even though we tried to do, but we actually could not do much about it. We could just do the roof part we could do because everything was herniated into the orbit. So So these are really difficult cases to do, and I think the accurate planning is required. So this I'll not talk about the encephalocele, which Ron has said. Then dermoid, you can get them. These are lesions which you can get them in midline. This is a typical dermoid which you can get. The problem is that they sit just over the sagittal sinus, so your dissection has to be very meticulous to take them out, or you might injure the sinus. You need a little bit wide opening and find out the bones on all the sides, and then you do the dissection without and very carefully so that you do not damage the sinus. This is again another case of dermoid with Klippel-Feil syndrome, where this is the dermoid. You can see this is not very difficult to take out, but of course you have to have your precautions. And if it is better, if you can take out in one piece, but it is also good. If you can't, you have to decompress it and then take it out. Post-traumatic abnormalities, Kefal hematoma, fractures, leptomeningeal cyst, like all these diagrams all are there. Like there's a calcified Kefal hematoma. I think Federico has also shown the one of the diagrams, and this could be Kappa succedatum, where it does not respect the sutural lines, but Kefal hematoma respects the sutural lines and remains confined to that particular region. And these are some examples. And this is one thing which is a delayed subgaleal collection after trauma, which can happen in children, then they resolve by itself with just regular dressing and drainage. But they are very rare, but sometimes they come, but sometimes you can see one or two cases, and you might not really find any good cause for the trauma. It could be a trivial trauma, or this particular patient never had any history of any trauma, but he came with this. He came for 3 months to us, and we tapped thrice just with a needle in the dependent position and put a pressure bandage. And after 3 months, it just resolved by itself. I still don't know what are the real mechanisms of this, but this was a case which we encountered. Now, this is a leptomeningeal cyst. This was a case of a macrocephaly and then had a fall, and after that had a leptomeningeal cyst. So I will then this is a case of a subgaleal collection. It can happen like this, post-trauma. And neoplasia, again, a little bit hemangiomas are common in children, especially in this one, but they resolve by itself. And if at all they don't resolve, even alcohol can be given to, and just alcohol injection can be marvelous for this sort of cases. You do not really need to do anything surgical. So this is one case of a 3-day-old baby. And this is a case of a fibrosarcoma. This boy came with an ulcerated tumor, of course, because of the huge size. And then we operated, and it came out to be a fibrosarcoma. And this is a case of a Ewing sarcoma, which you can see in the adolescent group rather than in the lower age group. And you need to surgically excise them thoroughly as much as possible, and because they are not very sensitive to radiation. So in summary, I'd like to say that congenital anomalies of the skull can be divided as this article is very good, incidentally detected on imaging, or it can be visible or palpable normally. There could be granulations, arachnoid cysts, parietal foramina, sinus pericranii, venous leaks, intraosseous hemangioma. Present at birth could be Kefal hematoma, congenital depression, skeletal dysplasia, aplasia cutis, venous malformation, dermal sinus, meningocele, and cephalocele, anterior, posterior, wherever. Present later in childhood could be infantile hemangioma, calcified Kefal hematoma, neurofibroma, osteoma, lipoma, and the symptomatic ones like Langerhans cell, histiocytosis, Ewing's, osteomyelitis, osteosarcoma, lymphoma, and metastatic. And with this, I end and finish my talk. In conclusion, this need to be addressed early. All these lesions needs to be addressed early, except for fibrous dysplasia. If it is for a cosmetic region, all of us should put our effort in creating awareness, because many of them go unnoticed. Majority of congenital anomalies are treatable and not life-threatening. Thank you.
Thank you very much, Suchanda.
I'm unable to open my video somehow.
So thank you very much for this large review of all the anomalies. And we have seen how rich they can be. I don't see questions from the audience, and I think we are a little late. So probably we'll let Alison go to sleep. And Arthur, do you want to conclude?
Yes. Thank you very much, all the speakers. This is a really wonderful webinar, very informative, and the ISPN wait that we can organize for next year. So good webinar. So we had today. Thank you so much. And we close the section.
Thank you. Bye.
Bye-bye.
Bye. Bye-bye.